Well, good evening, everybody, and thank you for joining us for this very informative session on medications in pregnancy with Dr. Penelope Fotheringham. I'm Sandy Vincent from the PHN Education team, and before we begin, I would like to acknowledge the traditional custodians of the land that we live and work on. For me, that's Darkinjung land, and I would like to pay respects to First Nations people for their enduring culture and the contributions they make to this vast region. As always, just a couple of things to let you know. This session is being recorded and the recording will be available to you in the PHN library in a couple of days. A short evaluation will come to you automatically at the end of the session, and we'd be very grateful to have your feedback. If you do have questions, and we welcome questions for the session, please use the questions box. You'll find it in your panel. Just use the little arrow to drop down the box, and then you can type your questions into that, and we will review all of those questions at the end of the session. So it's now my great pleasure to introduce our speaker, Dr. Penelope Fotheringham, who is a dual-trained medical specialist in obstetrics and gynecology and public health medicine, who also works as a medical advisor at the maternity services in the Central Coast Local Health District. She has been teaching medical students at the University of Sydney since 2010 and also lectures in Masters of Medicine, Sexual and Reproductive Health. So it's my great pleasure. Thank you very much, Penelope, for joining us tonight. I'll hand over to you.
Thank you. I will just share my screen and get this up. Fantastic. So thank you for having me speak to you today. Some of these slides are quite complicated, so it might be that you need to look at the resources afterwards. Obviously, I'm very happy to answer questions. And the reason that I am speaking on medications in pregnancy today is because I'm currently working at Mothersafe, and it is obviously an important area for advice for women in preconception, pregnancy and lactation. I will be going quite quickly through things, so I do apologise, but as I said, the resources will be there afterwards for you to use. So why do we worry about medications in pregnancy? And why is Mothersafe important? So it's a New South Wales-wide state-free service, and we give advice on exposures in pregnancy and lactation. It's run out of the Royal Hospital for Women in South East Sydney. It was established in 2000 and by Dr. Deborah Kennedy, who's a geneticist and paediatrician, and there are some other clinicians such as myself that work there. It is a free service and it is New South Wales wide, which is very important to people that live in regional and rural areas. I always choose the next slides. So what is the role of Mothersafe? What we want to do is provide evidence-based information and advice to those that need it. So that could be healthcare providers of any form, as well as consumers regarding exposures to medications that they are taking in preconception, pregnancy or breastfeeding. And as you can see, it's not just related to prescribed medication. It includes illicit substances, food, chemical exposures, radiation, occupation, environmental exposures and infections as well. The other roles that we have is emphasis on counselling and follow-up and research. So when we see women who are on medications who've become pregnant, then we can follow up with them for their outcomes. Collaboration with other services internationally. We provide education such as this to healthcare providers and students. And there's also many evidence-based fact sheets which you can find on the website. So that's a picture of Deb Kennedy, acknowledging that she's the one that started the service. For those that have more complicated medication advice in preconception or pregnancy, then they're seen by a clinician such as Deb and myself, and a dated referral from a doctor is required. And that generally is done via telehealth medicine to enable equity of access for people throughout New South Wales. And reasons for referral, as I said, are complex cases, known exposures to ratogens, and people who may be considering termination of pregnancy or been advised to terminate a pregnancy due to exposure concerns. So it's very important, obviously, that those women have appropriate advice for the medication and the risk to their pregnancy based on the exposure. So as you will all know, working in primary care, that the majority of women will take at least one medication in their pregnancy. So this could be short-term use of medications, so because they have nausea and vomiting in pregnancy, reflux, hemorrhoids. It may be because of non-pregnancy related conditions that coincide with pregnancy, such as hay fever. And obviously many pregnant women also have pre-existing chronic conditions that require ongoing use of medication throughout a pregnancy to ensure that maternal health is optimised. And it's obviously important because a medical condition that needs medication outside of pregnancy doesn't disappear because someone is pregnant. So those conditions need to continue to be untreated so they don't cause adverse health effects for the mother and equally adverse health effects for the fetus. What we talk about with women is a background context for all pregnancies of what the risks are. And it's important to understand on a population level that there is a 2 to 3% chance of a baby being born with a major birth defect. So cardiac anomalies, neural tube defects, those sorts of things. It's also very important to acknowledge that if you think about neurodevelopmental disorders, this goes up to 5%, and that is independent, obviously, of inherited risk if there are family members who have neurodevelopmental disorders. There's also a background risk of miscarriage, which is approximately 15% dependent upon the research that you look at. So it really is important that when you think about risk with medication exposures, they're expressed in relation to these background risks. They're not independent from them. And as we know, approximately 50% of pregnancies in Australia are unplanned. So it means inadvertent exposures to medications in pregnancies are very likely. And it means that these are the things that people will be thinking about both as consumers and clinicians. So thinking about risk and what is it? So we know that we call medications that are known to cause a congenital anomaly, teratogens. Obviously, though, the overall effect will depend upon the dose of that medication and the timing of the exposure. Medicines really are not the main culprit for birth defects. Most medications are not associated with teratogenic risk, even though consumers and potentially many healthcare professionals have concerns regarding the harmful impact on the unborn child. We also know that consumers increasingly are looking for other sources of information besides healthcare professionals regarding medications and their use, and may be very well informed or sometimes misinformed regarding their risks of medications for preconception and pregnancy. So it's important they are able to speak to someone appropriately about this. So it is really important that doctors, and especially as you working in the primary healthcare area, because you are the people that are going to be seeing these 50% of women with unplanned pregnancies, that you are able to really confidently and appropriately provide information to women, evidence-based, and make recommendations regarding medication use in pregnancy. Obviously, as well as alleviating any concerns that people may have about the ongoing need for medication to treat a chronic medical condition. And it's really important that you are mindful of what you say, because some things can be unheard, and we don't want a woman to hear that, you know, the medication is unsafe and then she stops taking it in pregnancy and then has an adverse outcome for herself and her baby because of this, which could have been avoided as the medication wasn't actually that harmful in the first place. So thinking about the considerations for prescribing medications to a pregnant woman, the things that you need to think about are, is it known that that medication can cross the placenta? And if it does cross the placenta, what potential consequences are there of fetal exposure? Do we know it's associated with an increased risk of miscarriage, structural malformations, or adverse pregnancy outcomes? What is the impact on the baby after it's born? But equally, it's important to consider the harmful implications of the maternal condition not being treated, which in many cases outweigh the risk of the medication itself. So really, it's thinking about risk versus benefit, which is what we do with every consultation when we see our patients. Thinking about, you know, the benefit of the mother in using that medication versus the risk to the fetus of using that medication, and thinking about the dose and the critical periods of timing and development which we may need to navigate around when assessing risk to that pregnancy. So this is a reminder of your embryology, thinking about human development, and you can see in that, looking at the different weeks of pregnancy, dated in the purple from the last menstrual period, which is what we commonly use, that there are periods of time that are less sensitive for certain organ developments and periods of time which are more sensitive for different organ developments. And that's important to understand because it may help us to navigate medication use in pregnancy and recommend one medication for a certain trimester of pregnancy, usually the first, and then potentially after that period of time to change onto a different medication, or vice versa, dependent upon what the thing is that you're concerned about with that particular medication. And this is just a quick note about complementary and alternative medication use in pregnancy. It really is an industry where there's a lack of regulation and standardization of products, as you know. We don't have an evidence base of studies which either usually demonstrate efficacy, or we don't have any safety studies in pregnancy. So really, regardless of what the substance is, when someone comes to you and they're asking about alternative medicine use, we generally don't have enough information to be able to say that there is a benefit of that medication versus the potential harm that it could cause in a pregnancy. There are some herbal remedies which we know are associated with harm in pregnancy, which are things such as abortifacients or can cause uterine contractions. So we have evidence for those things, but they're generally not the things that people are using currently in the complementary medicine space. So our approach at Mothersafe is generally, if we aren't sure what it is, what is in it, what the dosage is, or there's no information about non-harmful effects of it, that the advice is not to take that in pregnancy. So the challenges that you have in primary care, obviously you're very busy. You have limited time in your consultation to counsel pregnant patients. You have limited time to conduct in-depth research to find resources about medications they're on. Often people are worried and lack confidence when providing advice in pregnancy because they're not sure of the resources that they could use, and they potentially are worried about any risk to a pregnancy with a medication. And equally, if you look at different references, it can be very confusing because the advice varies greatly between different sources, which creates lots of confusion and concern. So I'm going to point you at the end of this to some resources which are better to use and will potentially mean that you can be able to give advice to your patients and feel more confident about this. So when would you refer to Mothersafe as a service? If there's no pregnancy data, then that's obviously something where we can help because we have access to other sources of pregnancy data internationally with regards to medications. And this can also be where the information is unclear and conflicting and you're not quite sure which one you should be trusting. Obviously, if an exposure has already occurred and medical information suggests some risks, then we are able to discuss that with people. As we said before, complicated cases. If you are worried or the patient is worried, then it's important as well to think about referring to us or to another equivalent person who has confidence with counselling people regarding medication use. Obviously, if you're not sure about a drug or prescription for a medication, then it's important that you check what that is before you tell the patient about the risk of this. So this is an example of where different advice from different resources come from. So acyclovir, you all know, hopefully you will prescribe it to women in pregnancy and feel confident using it. But if you look at the different categories, potentially it can cause a lot of confusion. So the TGA category is B3, which we'll discuss through later on in the slides. If you look in MIMS, it says tablets should not be used. Also says that topical cream should not be used despite the decreased absorption of this. If you look in the AMH, it says it's safe to use. And if you looked at the Royal Women's Hospital Pregnancy and Breastfeeding Guide, then it says, yes, it's also safe to use. So if you had someone sitting in front of you and look at MIMS, you'd be like, don't use that medication. If you look at AMH, it'd say, yes, you can use that medication. So which one should we trust and why? So it's important to think about manufacturer product information and where that is put, and that potentially is influencing that first column where MIMS was. So when you read product information, it's obviously a medical legal document that the company is required to produce for that medication. Generally, it is very conservative, and the wording is normally proofed and approved by lawyers for companies to ensure that if there is an inadvertent side effect of a medication, that they are not held responsible for that. Because of this, almost every medication recommends that it should not be used in pregnancy or breastfeeding. When further information comes out, once medications have been around for a period of time and we have further information from clinical trials separate from pharmacological trials, these product information statements are generally not updated. So it means that we're looking at information that is out of date. So it's not really a reliable source to assess safety of medicine use in pregnancy. Thinking about the TGA categorization system, so you'll be familiar with that. There's A, B, 1 to 3, C, D, and X. It causes a lot of confusion. It's very common for people to think that the system is really reliable and it's giving us information about the medication that we can look at quickly and know if it's a category C or a category D. I know exactly what that means for that medicine and what I should say to the consumer in front of me. Things that people often think, which are not true, is that the alphabetical letter code is a ranking of risk. So an A is better than a B1, better than a B2, better than a B3, and so on. But this is important. It's actually not hierarchical, and it's somewhat misleading in the way that they've ascribed those alphabet codes to it. For example, if you're looking at category B, they're generally not safer choices than a category C drugs, because when the whole point of category B, when you read it, is that we don't have human data, which is associated with these drugs being used safely. So a lot of people will look at a B and prescribe that over a C when it may not be the appropriate choice. Equally, internationally, there is a move away from the use of pregnancy categories because of things like that being misleading for clinicians and patients when we're using medications. The US FDA, they don't use a system such as that anymore, so they really have more comprehensive information about medications compared to the previous letter categories that they used to use. You'll note that that Australian Medicines Handbook excerpt didn't have a pregnancy category in it when they were describing it. They just said it was safe for pregnancy with that previous example. And in New Zealand as well, they've taken away the categories that they used to use in medications because it was quite misleading. So these are some examples. So we think about antidepressants that you may see with your patients. So citalopram is a common medication. It's given a category C. We have large numbers of studies internationally published about SSRI use in pregnancy over many decades. Maternal use of citalopram is not associated with any increased risk of congenital malformations based above the baseline risk. There is potential for neonatal adaptation concerns, which are transient and generally mild 24 to 48 hours after birth when the medication is used, especially in the 3rd trimester. We have a lot of data about long-term behavioural and cognitive outcomes of children when mum takes an SSRI in utero, and there's no significant difference compared to non-exposed children. And yet this is a category C drug. So if you just looked at the category C, you'd think, oh gosh, I shouldn't have anyone on this drug in pregnancy, even though it's not associated with any structural changes. There's no long-term problems for children with it. And there's really the things that we worry about are the mild transient adaptation problems for babies. And often people talk about as well, there's a really slight increase in persistent pulmonary hypertension for people on SSRIs in some studies. Comparing this to another medication, so vortioxetine, which is in category B3, we don't have reports on this medication, its use in pregnancy in humans. We think, yes, as with other antidepressants, there could be neonatal adaptation problems, especially if you're using it in the 3rd trimester. We have no long-term studies on this medication. So if you compared these two and just went simply with those categories, you would think that citalopram was less safe, even though it's actually a medication which is more reliable to use in pregnancy because we have far better data to be able to discuss with the patient sitting in front of us. So that's why an example of why they're a little bit misleading and why really thinking about why the person needs that medication and really looking into the information about it is important rather than just going to that TGA category. So when we think about pregnancy categories as well, the other important thing is that they don't tend to change them. So once something is assigned to a drug, it isn't reviewed over a certain time frame. It's actually the manufacturer that would be responsible for initiating a review. And as I've already intimated, they are going to be thinking about it from a medical legal perspective rather than a pragmatic approach to thinking about the appropriate medications that people should be using in pregnancy. Another quick example, so mebendazole, medication's been around for a very long time. It's a category B3. It's not well absorbed, so it's not really a systemic medication. The WHO says it's an essential medication for treatment of helminth infection, obviously because of untreated helminth infection has significant sequelae. We've got significant amount of data regarding pregnancy exposures to this medication that does not show there's any adverse outcomes. So really when we're thinking about this, obviously weighing up risks versus benefits, this medication should be used for the treatment of infections in pregnancy to make sure that we have eradication, therefore none of the complications of it. Yet if you just looked at category B3, you would think, gosh, I shouldn't use this medication. So the other thing that's important is, as I've said, that the manufacturers have influence on those drug categories. So they can actually say, well, we actually don't want this drug to be used in pregnancy and breastfeeding, and we want it to be more restricted. So that's also something to be aware of when you're looking at it, because the TGA may actually think it's in a medication that would be a category A, but the manufacturer can request that it's not put into that category. So another example, doxylamine, it's a sedating antihistamine, category A medication now, and you would have hopefully seen the hyperemesis guidelines that New South Wales Health has put out that has that in there in the treatment algorithm. So it's internationally has been marketed for nausea and vomiting in pregnancy for many, many years. However, until very recently, it was said in the product information it should not be used in pregnancy. And in Australia, we didn't have any advice locally that we were happy with it to be used in pregnancy. So it has recently had its warning category changed, but this isn't consistent depending upon the brand that you look at. So it may be in some medications where it still says, no, you can't use it, do not use in pregnancy, should be avoided in pregnancy. Whereas actually internationally, it's a medication that people are happy to use and prescribe regularly. And equally, people can get from the chemist. And then the other important thing is thinking about that drugs in the same category often don't carry the same risk. So if you look at the category and you have something in category B, 3, C, they don't actually differentiate the level of risk within those categories. And that's important as well, because the other thing that you're thinking about is the dose of a medication that someone is taking and the route of administration. Is that topical? Is that inhaled? Is that oral? The medication, and thinking about how that is absorbed. And that acyclovir example from earlier illustrated that. So another comparison here, so sodium valproate and paroxetine, both category D. You probably know about valproate as a medication that is associated with one of the fetal valproate syndrome, so one of the anticonvulsant medications that is known to be associated with things such as neural tube defects, cleft palate, cardiac anomalies. The risk is far higher at greater doses or with polytherapy with other medications compared to paroxetine, which is also category D. There's some studies that show maybe there's an increased risk of heart defects, but obviously with that medication, if you're thinking about the impacts, if you're very concerned about it, you wouldn't use it in the first 10 to 12 weeks of pregnancy, but after that, it would be fine to use. So it's important to think about those things when you're thinking about the category as well, if that was the thing that you were looking at, to make sure that you're appropriately interpreting the medication and its use. And another example there of fluconazole, which you can have a look at. And then just thinking as well about the different routes of administration, so cream versus tablet. Obviously, you're going to have less systemic absorption if you're using something topically compared to something which is orally. So that's important to think about as well when you're using a medication, to think about the risk versus benefits, because there's going to be minimal, even if a medication crosses the placenta, if there's minimal absorption when you're using it topically, there's not going to be enough concentration that would go through to the placenta to potentially cause fetal complications. So as we said in that diagram earlier, the timing of an exposure is a critical factor when thinking about risk. And really, if you're going to have that problem, you have to take the medication at that point in time when it's going to cause a problem. So that's why it is so important to think about when the exposure is and which medications we take at different stages of pregnancy to minimise that. So you will know about things like tetracyclines. They're said to be category D when you look at them. They are safe though, really, in the first 18 weeks of pregnancy, and you sometimes may only have the option of using a tetracycline because of resistance to other medications. Obviously, we don't want to use them later in pregnancy because they can have impact on bone growth in the fetus. They can also cause discoloration of deciduous teeth, which is important, obviously, for long-term impacts on the baby. So even it's a category D because it can cause problems, but it doesn't mean you can't use it in all stages of pregnancy. And as I've alluded to, the categories are not providing a clinical context to the risk. So they're not saying if you use it once versus if you use it throughout the pregnancy. They're also not considering the implications of a medical condition not being treated. So obviously thinking about doxycycline, if you have malaria, you need to treat that for both maternal and fetal well-being. If you have a condition such as acne, there are alternative medications you can use to treat that as opposed to doxycycline. Another important example is nicotine replacement therapy, which is currently category D. And obviously we know nicotine is something which is toxic. It's something which can go through to cause exposure to the embryo and the fetus. But obviously we want to think about the risks and benefits of smoking in pregnancy. So obviously you will all know the negative associations that smoking can have with pregnancy. So if people are at a stage where they're ready to consider stopping smoking, then they may need nicotine replacement therapy as an adjunct to other counselling, which is obviously offered for people who wish to stop smoking. Thinking as well, cigarette smoke itself, as you know, has multiple compounds which could potentially be harmful to the pregnancy and the fetus. So we want to use nicotine replacement therapy as a harm minimisation strategy for people who are motivated to quit smoking and who may need this in adjunct to non-pharmacological strategies. And really, if we're trying to use the lowest effective dose, that's important. We're thinking about the route of administration, so thinking about fast-acting NRT potentially rather than patches which last for longer. And the current advice in Australia is usually not to use patches for 24 hours and to use them for 12 hours overnight, whereas international guidelines don't suggest the same things. But obviously, nicotine replacement therapy is always going to be preferable to smoking, but it's a category D. And then thinking a little bit further, so obviously these are pregnancy categories we've been speaking about. So they only apply to pregnancy. It's not a reference when you're thinking about breastfeeding with medications because that is a different route to the fetus. Equally, some drugs that are considered safe in pregnancy may not be considered safe for breastfeeding. So why is that? So you know the benefits of breastfeeding. Obviously, it's something which we wish to promote for women who wish to and are able to breastfeed and to give them the supports to do so. many women, as with pregnancy, will need medications while they are breastfeeding. Again, it might be specific treatment for complications of breastfeeding and maybe a continuation of their treatment of their chronic conditions. They may develop acute conditions or other conditions during the time that they are breastfeeding. They may need other preventative medications, such as vaccinations in this time frame. And equally, we need to think about substances that people use socially, such as alcohol, caffeine, or illicit substances, and what their impacts would be with breastfeeding. So most medications are considered compatible with breastfeeding, but unfortunately many women are advised to stop breastfeeding, often unnecessarily, when they're taking a medication. And even though that doesn't seem like a lot, to say, look, you know, you're on this medication, you need to take it for 5 days, why don't you just not breastfeed in that time? It can be very difficult for women to do that, to withhold or cease breastfeeding. And generally it disrupts and causes ongoing complications for them, and it may end up with people ceasing breastfeeding because of that. So it is something which you have to be quite careful discussing with someone, because there are potential adverse health consequences for both mum and baby when we're talking about a medication not being safe in pregnancy, either because the baby doesn't get the benefit of breast milk, or the mother decides not to take a medication because she's worried about risk and her condition deteriorates. Again, when you're thinking about how information is written about lactation as it is in pregnancy, again, the same medical legal defensive language is used that will usually advise about not taking a medication while you're breastfeeding. This will be with a lack of evidence normally, because as with pregnancy, we don't have large numbers of studies on medications. Most clinical trials exclude pregnant women, and often used to, but don't always exclude women of reproductive age as well. There will be a lot of misinformation that people are hearing about medication use in pregnancy, either due to friends, family, online chats, etc. Equally, it depends upon someone's wish to breastfeed and how strongly they feel about that, which is why any interruption to breastfeeding may be something which is concerning, because it may lead to someone stopping breastfeeding. And equally, we know that mothers want to be safe for their children. So if they are not going to wish to do something which is going to cause harm to their child, they would rather cause harm to themselves than harm to their child with medications. So another example of a medication that isn't potentially accurately described when we're thinking about lactation. So when you look at the product information on metronidazole, it says you shouldn't be taking it while you're breastfeeding. Obviously, that doesn't make sense, because children are given metronidazole as a medication or treatment. So that doesn't make sense, because obviously you're thinking, well, if someone is breastfeeding and it's maternal plasma levels, the baby is going to get very small percentages of that. And we're happy to give a 1-month-old 7.5 milligrams per kilogram of this medication every 12 hours. When you look at the Australian Medication Handbook, it clearly says it's safe to use, which is a great resource. And if you looked at the Royal Women's Hospital guideline as well, it says that it's considered safe to use as well. So why, again, is it so different? So as I've alluded to, that women who are breastfeeding are not going to be included in any pharmacological trials, which means that we don't have initially any lactation-specific information. When we think about the TGA, they're not going to be approving medications because of the lack of information, and also because potentially requests from the pharmaceutical companies. Generally, when we do get evidence, it's only after the medication has been used for a period of time, and then it's really low volumes of cases that we can use for our resources. And as we've talked about previously, they're not going to update their resources when they have data coming out. So this makes it challenging, because if your patient looks up the information that is given with that medication, it will almost invariably say you should not be using this when you are breastfeeding, and that causes a lot of anxiety for those individuals who read that information. So words that you will see in breastfeeding information or breastfeeding advice in product information, it may be something such as reassuring, which is generally something we'd be happy to use, where it goes down to no specific recommendations, so we don't have any information on that. And then things that potentially make you more concerned are cautionary and suggesting avoidance. So that means that there may be evidence that we should not use that medication when someone is breastfeeding. And another example here, which is quite interesting, so when you're thinking about someone who has mastitis and what you would treat them, if you look at the therapeutic guidelines, it very clearly says we should use either dicloxacillin or flucloxacillin. And then when you look at the product information for Diclox, it says caution should be exercised if you're giving this medication to a nursing woman. If you look at Fluclox, it says an alternative feeding method is recommended because they're concerned about it. So we've made recommendations to use medications and then they potentially shouldn't breastfeed on them, which is obviously something we don't want to happen with mastitis. They need to continue to emptying the breast to minimise continuation of that condition. Then when you look at it further, we've got Keflex and clindamycin as alternative medications there if you cannot take a penicillin. Again, looking at Keflex, it says caution, alternative feeding arrangement should be considered. When you look at clindamycin, it says clindamycin is not recommended for nursing mothers. So that causes quite a lot of confusion because the drug information that is given in the product statement is something which contradicts the use of the medications for women that are lactating. Again, going back to the Australian Medicine Handbook, which is a nice resource to use if you're going to choose one as your go-to resource, it clearly says there that Diclox and the other medications are safe for breastfeeding. And equally thinking about, as we did before with metronidazole, all of these medications are going to be used in babies and children in neonatal doses as well. So that can be something which helps you reassure yourself about the use in breastfeeding. And then just to quickly mention off-label use of a medication, which you will be familiar with. So obviously that's when we prescribe a medication that wasn't originally used for that indication. We do this quite a lot when we think about breastfeeding and or pregnancy. It is something which is obviously a legal practice. It's very common. And the reason that we do it is because we know this medication is useful, potentially from clinical trials after the medication has been used and approved by the TGA. And so it's important that we tell the patients that we are using this for an indication that the medication wasn't originally used for, but they need to be confident that they can use that medication and it's appropriate for them to use it. So going back again to what we talked about with pregnancy, thinking about breastfeeding, the use of medications is still going to be that risk versus benefit. Thinking about the benefit for the mother and the infant. So I'll go through these pretty quickly because I think it's easier for you to read through them. But really, when we're thinking about harm versus benefit, the harm is if there is transfer of a large amount of that medication that is clinically relevant to a baby through the breast milk. The benefit is treating the maternal condition and supporting continued breastfeeding. As we said before, most drugs will pass into the breast milk, but they're usually in very, very small amounts. The extent of transfer depends on the maternal plasma concentration, which will obviously be influenced by the dose of the medication they're taking when they're taking it in relation to when they are breastfeeding. And that is influenced then by also the absorption of that medication, how it's being given, if it's oral or topical. To think about, well, how does that medication get into the mother's bloodstream and what plasma concentration of that can it cause? Also, obviously thinking about the half-life of a medication. So the longer the half-life of that medication, the longer it will stay in the system. So thinking if you're wanting to minimise the amount of medication in the that will influence the plasma concentration for the mother, you'll be thinking about using medications that have a shorter half-life. Some medications you have to think about the accumulation of that if they do have a long half-life or an active metabolite that has a longer half-life, because obviously then they can have influence on the baby. So things such as benzodiazepines are things that we would usually talk to women about with that in mind. And then thinking about the size of it, is it big or small? Anything that is a large molecule can't get into the breast milk, which is important. So things like enoxaparin. Things that are bound to protein are less likely to cross into breast milk. So things like warfarin and sodium valproate, which we're so worried about for pregnancy, but well, not so worried, but potentially concerned about for pregnancy, but we're not concerned about for breastfeeding. And then also thinking about the pH, so the acid-base balance of the medication. So something that is weakly basic is going to go through breast milk more easily, and something which is fat soluble is going to be in breast milk and transfer more easily. And then also it's important to think about how the mother processes a medication. This is where codeine is something that we are concerned about, and really in the last 10 years you would have seen that there's a change in the way we think about codeine in the postpartum and breastfeeding period. And that's because of people who are ultra rapid metabolizers of codeine, which means that they can produce significant amounts of morphine, which is obviously a metabolite of codeine in the breast milk, which can lead to lethal levels in the newborn, cause respiratory depression and death for babies. And there have been unfortunate cases where this has occurred. So again, thinking about pain relief for women, short-term use in low doses of codeine is probably going to be okay for the majority of women, but continued use of that medication is definitely something that you need to be thinking about. Or obviously, if you know that the mother is someone who has who does rapidly metabolize codeine, then you're going to be more concerned, or if there's polypharmacy being used for that child. And then thinking about factors for the baby that are going to be important. So the age of the baby is something you always need to think about. So thinking about prematurity versus full-term babies with their organ development, obviously their size, what doses of medications that they will have, how that's going to be excreted because they have more immature liver or renal function. Also thinking about how that medication is going to be delivered to them. So they will potentially be having less milk over time because they don't suck as well, they have small quantities of milk, they have a bigger interval between feeds, and they have supplementary feeding as well. A term infant is at lower risk than a preterm infant when thinking about medications being delivered to them. And obviously as a neonate grows and has increased weight, it's going to have decreased risk as well. When we're thinking about the dose that babies get, you will see that they talk about something called the relative infant dose. So they'll normally put some sort of percentage, or this is the amount, the percentage of the mother's plasma level that the baby is delivered. And generally when we're thinking about a relative infant dose, less than 10% of the weight adjusted maternal dose is something that we'll be happy with for breastfeeding for most medications. So this is an example of quetiapine. So it says, yes, it's excreted into breast milk. The relative infant dose is minimal, 0.02%. So we're not going to be concerned about that in general for women who wish to breastfeed on quetiapine. The thing that is important though is obviously thinking about doses. So higher dose of medication will therefore make sense, higher maternal plasma volume, higher dose to the infant. Also, there are some medications which are potentially dangerous to infants, even in small amounts. So that includes things like isoretinoin, chemotherapy agents, anything that is radioactive. And those things we would obviously counsel women about not breastfeeding on. And then also thinking about the next part of that cycle. So how is medication absorbed from the infant's gut, and how effective that is. So you can use the oral bioavailability of a drug to work that out. Equally, if you're not sure, you can call the Mothersafe to be able to find that information if you can't find it in the product information, because it can be difficult to find. And then we've talked really about potential for infant side effects, already thinking about gestation. But if we're concerned about sedating medications for infants, obviously that might mean that we need to monitor. We're concerned about side effects such as diarrhea, constipation. Obviously, they're things that you would need to monitor because they can cause the baby to become unwell. So it's just consideration of what those potential effects are and how we need to monitor for those. So as we alluded to before, if something it was safe to take in pregnancy, is it safe in breastfeeding? So the answer is not always, because of those different things that we're taking into account with placental transfer versus transfer through the breast milk. So it's important that you're thinking through those different things when you're thinking about the different stages of pregnancy that women will be going through. So it's important as well to, as we said before, thinking about, well, if we have paediatric experience with the medication, and that's quite helpful for us when thinking about breastfeeding. So I'm just going to skip through some of these slides in the interest of time, just in case that there's any questions, but you will know that there are medications that can increase or decrease breast milk production. Often that's because of their impact on prolactin. And then we've talked before as well already about thinking about harm versus benefits, and really again prioritising maternal health as well as neonatal health when we're thinking about breastfeeding. Do they need that medication? Can that medication be delayed? Is there an alternative to use? And just important thinking about postpartum maternal mental health, because really the common medications that we see women on are really antidepressant, anti-anxiolytic medications. And really it's important that the majority of these can be used with safety during breastfeeding. And we know that in the postpartum period, women have an increased risk of mental health deterioration. So it's important that we make them aware that their medications are safe, and it allows them to be well in this period, have appropriate bonding with their baby, and that they don't have a difficult experience in that postnatal progress time when they take their babies home. So this is just something which you can look at afterwards, a quick flow chart to think about breast milk, and is it something that we would be concerned about or not? So when we're thinking about prescribing in pregnancy, these are some take-home messages. If you can use topical, it's probably better than oral. Think about what dose you're using, the period of gestation when you're thinking about a risk assessment, as well as the maternal welfare. Don't rely on the TGA pregnancy category as your sole guide for assessing the safety of the medication. Be wary if it looks like things don't make sense because the medication has been around for a long time, but the data has not been updated. As for any medication, you should use the lowest effective dose for the shortest duration of time for any medication. And really you're individualising your approach to that patient's context when you're talking about harm and benefit. And practicing person-centred care means that we ensure we have appropriate discussion and education for people so they can give informed consent about their medication choices. General counselling principles. Be very careful about what you'll say, thinking about the impact of your word choice and phrasing and advice. Anticipate any barriers that people might want to discuss with you. Provide simple evidence-based medication, and as I said, tailor your advice. For lactation, really it is thinking what risk is there for the infant, thinking about premature infants, and there might be more risk than term infants. Avoiding things that are unnecessary. Again, use topical products if available. Use medications that we have lactation safety data for if possible. And if there are concerns, then think about impacts on drug-related effects on the infant, any impact on lactation, and again, individualising that approach of harm versus benefit to enable continuation of breastfeeding. So, important take-home points: the health of the mother is critical for her ability to look after her baby when she is breastfeeding, and it's critical for her when she's pregnant as well, to make sure that her baby can grow appropriately inside the uterus. So think about that with medications before you're telling someone to stop them. So some quick resources there. We've talked about Australian Medicine Handbook, the Royal Women's Hospital Pregnancy and Breastfeeding Medicine Guide. There's the ATG. There is SEER, which you can access in New South Wales Health if you have access to that, where you can find reprotox. There is as well mothertobaby.org, mothersafe.org.au, and the Medicines in Pregnancy or UK TIS bumps, which have all free resources you can access via Google search that give you up-to-date information about drugs and their use in pregnancy with the information that we have from our current evidence base. I'll skip through that one. And just quickly on paternal exposures as well, there is a fact sheet that you can read through. Generally, they're not something that are of a concern for the majority of medications, but there are some that we still are concerned about. So if you're not sure, again, it's good to read, to ring us, or potentially look at those resources such as bumps, because they have information about paternal exposures as well. And Lactation for breastfeeding is very useful, which has up-to-date information about breastfeeding, and there is that is a free resource that you can get. So that is the end of the slides. I will just stop there and see if there's any questions.
Thank you.
If not,
Thank you so much.
If not, I'll go back to those.
Thank you so much, Penelope. That was really excellent. There was just so much great information in that. I will, just for everyone online, I'll definitely make sure Penelope has given us her slides, so we'll make sure that a PDF of those will come out to you, because there was lots and lots of things in there I'm sure you were scribbling down. I actually don't have any questions in the questions box right now, so please, for our attendees, do send your questions in. We'll wait a minute to give you a chance to do that, using the little box where you see questions, and you can type in there. Alternatively, you could unmute yourself if you wanted to just ask a question.
I'll just say as well, at the end of the slides, that there's a few extra recommendations for lactation resources as well, that you can look at. So when that PDF's out, then it might be helpful for people to be able to look at that, and then they can save some tabs on their computers, so when they need to look up a medication in a consultation, they can quickly access those.
Absolutely. So Gordon Lau has sent through a question. With more of us travelling again, I've had some patients ask about Phenergan for their infant to help with travel. How safe is that?
So it would be individualised, the advice that we would give, because it depends, as we've said, on the gestation of the infant, how we would give that advice. So if you're not sure, then tell the patient to ring Mothersafe and they can use it. And generally people do use Phenergan. If they're using it appropriately prescribed doses for infants, it should be fine if they're using the appropriate dose for that gestation. Obviously, sedating your infant on a plane, there are other ways as well that we would discuss with them to be able to manage their child on the flight, rather than medication to sedate them. But yeah, that's one of those things that if people have questions about it and you're not sure, someone has asked you and the child isn't in front of you and you're not 100% sure of the answer, then tell the consumer to call Mothersafe, and then we'll be able to give them advice and they can give us appropriate information about the, any risk factors for that child.
Thank you. Alicia sent through a question. I've seen conflicting information about meds for GORD in pregnancy. What is first line now? Ranitidine is not available.
Yeah, and so I think this is another area where the information hasn't been updated. So when you're looking at things like omeprazole, pantoprazole, you'll see conflicting information even though they're the same drug class. And generally we're not worried about using PPIs in pregnancy. There is more information on things such as omeprazole for use in pregnancy. But when you look at the information, when you're looking at MIMS and looking at the TGA categories, it doesn't really reflect that. Again, we get women ringing all the time that we're happy to give advice to through Mothersafe about that. And if you look up the BUMPS or the UK TIS advice sheet for that, it quite clearly says that we don't have significant concerns about their use in pregnancy.
Awesome. I think that's all the questions.
Fantastic. But as I said, there's lots of those free resources that you can look at. So it'll reassure you as well when you're discussing with your patients. And equally, you can easily direct them to, not just to us, but if you want to direct them to resources such as BUMPS, they can go in and look at it themselves. And they also have nice leaflets there that you could search for a medication and print out if you wanted to give that to a patient, which is always useful as well, that they have something they can take home to show to other people in their family if they've been concerns about that.
Fantastic. Thank you so much, Penelope. Yep, there's no more questions that have come through, so it just remains for me to say thank you so much for all of your excellent information tonight, and thank you for joining us tonight. It's been really awesome. So with that, I would like to say good night, and good night to everybody else. Enjoy the rest of your evening. Thank you very much.